Good evening, everyone. My name is Suzanne Brock, and I'm the current president of the League of Women Voters of the Cape Cod area. Thank you for joining us tonight on our webinar dealing with suicide prevention and understanding the mental health needs of older adults and people of color. The League is a nonpartisan organization that seeks to help people engage in the civic process. Individuals who join the League of Women Voters of Cape Cod automatically become a member of the League of Women Voters of Massachusetts, as well as the League of Women Voters of the United States. So you are included in across a whole gamut of local, state, and national boundaries. We do our work of education on civic issues and advocacy on legislation and policy by studying and coming to consensus on a number of issues that we then develop a position on. And we use these positions in order to work towards education of citizens and advocate for or against bills that fall within the purview of our positions. Today's forum is dealing with a local issue and is the result of study by our health committee, chaired by Pat Ryle and Sally Cahill, and we thank them very much for their leadership. It is now my pleasure to introduce our moderator for the program, League member Eileen Ellis. Eileen is a former Massachusetts Commissioner of Mental Health and is presently chairs the Barnstable No Place for Hate. Eileen?
Thank you, and it's an honor to be able to speak to all of you and to know that so many of you have joined today's discussion on a very serious issue. And as you heard, it is a Cape Cod issue, but in fact, it's a national issue as well. And its impact, which you'll be hearing more about this evening, on our older adults, our youth, our adults, but particularly in regards to youth and to adults, those of color. We want to be able to take the time to ensure that each presenter is heard and not interrupted. Please use the chat box, and we have left at least a half hour or more to address questions and provide answers from the panelists. We have three spectacular panelists who will in fact cover the issues around suicide prevention. In that, I would first like to introduce to you Karen Ellery Jones, and she is the Assistant Director of the Samaritans Group on Cape Cod and the Islands and coordinator of that program's Senior Outreach Program. And it's a major outreach program for the Cape. And we're going to learn more about what they are doing from a perspective that's very important. So Heather, thank you. And we're looking forward to hearing your presentation.
Okay, thank you so much. Whenever I get the opportunity to talk about the Samaritans, I'm absolutely thrilled. I know many of you know the Samaritans probably by the two signs on the Sagamore and Bourne bridges. We're much more than the signs, actually. We have been here on the Cape since 1977. We just celebrated our 44th anniversary, and we're very pleased with that. And I just want to tell you a little bit about our history, because we are still using the same principles that our founder, Reverend Chad Vera, built the Samaritans on in 1953. So Chad Vera was an Anglican vicar, and he was quite young in his journey as a preacher when he got called to officiate at the funeral of a 13-year-old girl who had taken her own life because she thought she had venereal disease, when in fact she had just simply begun menstruating, but she didn't have anyone to talk to about it, so she was really scared. So he stood over her grave and he said, "Oh, little girl, I promise you, I'm going to dedicate my life to ensuring that two things: people will always have someone to talk to, and people will always have an opportunity to learn about sexual education." So being a vicar, he didn't make a lot of money. He always had a lot of side gigs, and he was, really wanted to pursue suicide prevention, but he just sort of had to build up a little extra cash. So he was on holiday and he got a call from the Archbishop, and the Archbishop said, "Listen, Chad, I've got a really good gig for you. Come to London, be a vicar here in a very small church, and I promise you, you have carte blanche. You could do anything you want in terms of suicide prevention." Well, he was really, really excited about that because for the first time, he didn't have a lot of parishioners who were constantly asking him to do this and to do that. He started seeing people in the basement of his church. And this was for marriage counseling. And at that time, that was really unusual to have marriage counseling. And he would have what he called the church ladies serve tea and biscuits to the people who were waiting to see him. And he started noticing a really interesting pattern, that he would come out to take the next couple in or to take the next individual in, and half the people were gone. At first he thought, "Okay, ladies, what are you doing? Because all these people are not here and they've come to see me." And they said, "Reverend Barr, we just listen to them. We let them talk." And then he realized, you know what, I'm onto something. I'm onto that. If we just simply allow people the opportunity to talk, to vent, to unburden, perhaps that will help. So in 1953, at that time in London, there were 3 suicides a day, which is really staggering considering the population wasn't that big. He answered the first phone call from a person who was contemplating suicide. And it's ironic that here in the United States, we're just talking about, thankfully we're taking action on the 3-digit suicide number when London had it in 1953. Monica Dickens was a young writer. The last name probably sounds a little familiar. She was a great granddaughter of Charles Dickens. She wanted to do a story on the Samaritans. And Chad, being as pompous as he was, said, "Well, I'm sorry, you're not going to be able to understand a Samaritan unless you become one." So she said, "Okay, I'll do it. And, just because I want the story, I'm going to become a Samaritan." Turns out she loved the whole model of befriending. Moved to Boston, 1974. She founded Boston Samaritans. She came to the Cape and founded us in 1977. When you drive over the bridges, you'll notice the suicide barriers, right? Monica was instrumental in getting the Army Corps to put those up in 1983 and 1984. Before they were up, there were listed about maybe 56, 57 suicides. There has been, I think, a couple since that, but that certainly dramatically cut the number of suicides down. Before they were put up, Monica used to put on a big slicker, and she would be in the canal with a megaphone yelling, "Don't jump, come down, we will help you, we will listen to you." So she is, I love that story because today we still subscribe to the place where when people call our crisis line, we listen. We offer them a safe, non-judgmental place. And we welcome them as friends over the crisis line. Our crisis line receives about 15,000 calls every year from people ages, 16 to 85 or 90. They have all sorts of issues. It could be mental health problems, loneliness, depression, isolation, particularly since we've had the pandemic, we've noticed a lot more calls. And that is the foundation of the Samaritans, is our crisis lines. We recently partnered with the National Suicide Prevention Lifeline. Very exciting for us because we can offer the ability to do an active rescue, which we never were able to do before. And that is really good for the people who call us. We have been remote since March of last year. That has been a very interesting transition. And we like to think that we try to find the good things that happened out of COVID. And it was that we were able to expand our volunteer pool to get more people in to volunteer for us. And it was a pretty seamless transition. And it's something that we're really proud of. We also are non-denominational. A lot of times people will think, oh, Samaritans, good Samaritans, the parable, and that no, and it's important for us to say that, just as I know the League of Women Voters is very cognizant of the fact that being nonpartisan is really important. It's really important for everyone to know that the Samaritans are non-denominational. So we have our crisis lines, which is what we were founded on. We have our senior outreach, and I'm going to talk about that after I talk a little bit more about mental health in older adults. We have Safe Place, and Safe Place is a group for people who have lost members of their family, friends, or coworkers to suicide. And it is a peer-run support group that meets once a week. We tried doing the Zoom meetings, but that just didn't quite work out. So we have been asking folks to go to Boston via Zoom. They have a fantastic Safe Place group there. So once we go back to meeting in person, we'll have our meetings here. We have something called a Caring Connection, which is one of our newest programs. And that's a really exciting program because when people are released from the hospital following a suicide attempt, that is a really critical time for them. It takes often several weeks, even months, to see a therapist. So the Caring Connection pairs a Samaritans trained volunteer with the individual who's been released from a mental health facility to sort of like hold their hand as they go through their journey, get them to a better place, get them involved in their therapy, and then we let them, we wean them off the system. That has been such a successful program and well needed. A Second Chance is our last program that we run, and that's for people who have attempted suicide. Again, we run that as and when we get enough people to join the program. So when I had said that there's about 15,000 who call our hotline each year. These are calls from people in Massachusetts, but also all across the country. And in fact, we have calls from England, from France, from Asia. And I always thought, and when people say, oh, you're the Cape and Island Samaritans, you just must get calls from the Cape. But it's like, no, we get them from all over. Who calls us? More women than men. And that doesn't probably surprise anyone who's in social services or suicide prevention. We have many regular callers who check in with us once or twice a day, sometimes 3 times a day. And that's because they lack the social connection that is so important to us. A lot of them suffer from isolation, undiagnosed mental health disorders, substance abuse disorders, etc. As far as older adults, we know that they face unique mental health challenges. Social isolation is one of them. And again, I think that that has certainly increased over the past year and a half because of COVID. So social isolation, I always want to change this word because I always get tongue-tied on it. I was practicing it before. It refers to having few or infrequent social contacts, and it's very objective. It's a physical separation, like living alone. Nearly 1 in 4 older adults are considered to be socially isolated. What are some of the most prevalent causes? Living alone, inadequate family relations or support, caregiver burden, a move. Bereavement is probably one of the strongest indicators. Illness, mental health, poor health, financial limitations. And then we have loneliness. Loneliness is a very subjective feeling about the gap between a person's desired levels of social contact and their actual level of social contact. In other words, feeling alone in spite of social connections. We know that our brains are wired for connection, right? Beginning like 2.6 million years ago, early humans started collecting food together and started realizing that, wow, if we band together, we can, be safe from predators, we can procreate. And it's really, really fascinating that, as we have evolved, the need for this social connection has increased. Ironically, in the age of the internet, we're sort of like pulling away from that social connection. We know that when people, older adults, are lonely and they're isolated, it negatively affects their health, right? It increases their risk for death from 26 to about 29%, which is staggering. Poor social connection and isolation raises the risk of cardiovascular disease by 29%, stroke by 32%, risk of dementia increases to 50%. It rivals well-established factors for morbidity, including obesity, physical inactivity, and air pollution. And we know that there is a cognitive decline associated with prolonged isolation. The growing evidence that social isolation and loneliness significantly contributes to deaths by despair, such as alcohol, substance abuse, and suicide. Older adults also are likely to experience, significant physical challenges in addition to the isolation and the loneliness. They're more likely to have a chronic health condition. 85% of older adults have one chronic health condition. 60% have 2. And this may lead to social isolation, depression, and loneliness. I think for me, the statistics are really troubling, particularly if we look at older adults, that they only make up about 12% of the population, but account for about 18% of all suicides. Suicide rates for 65 years and older is 32.5% out of 100,000. Now, if we look at Cape Cod and we look at these statistics, that we're, I think, one of the oldest counties in the state, maybe even the country. Barnstable is an old county. We know that everyone's getting older. We know that in fact is going to make the suicide rate go up. There are approximately, in the United States, 48 million people over 65 in 2015. By 2060, there's going to be 98.2 million. So for me, again, that's really staggering, is that we have to look out for the population of older adults who are more at risk for suicide because of social isolation, loneliness, and physical health challenges. How can we reduce the risk for suicide in older adults? We have to increase the social connectedness. And that's really difficult to do, but in order for us to thrive, to survive, we all have to thrive together. We have to design community programs to encourage this connectiveness, and we also have to expand mental health programs and access to them. And everyone knows who's in the mental health field that this is a perennial problem. What did we do at Samaritans to help the older adults? We started the Senior Outreach Program. That's a program that connects Samaritan-trained volunteers with older folks in the community who were lacking a social connection. They call once a week. They call their senior, and it operates on confidentiality. And it's really, really important that the seniors feel comfortable kind of discussing things that they might not want to talk about to maybe their children or to their neighbors. We have currently 69 seniors enrolled in the program. And I know it's my program and, you know, I'm really proud of it, but it's so simple and it works so well. And again, it stresses a connection. When people have a connection, they feel better.
Thank you very much. That was so complete and thorough.
I was getting the notices on my watch. I'm like, uh-oh.
You
So thank you.
Very good job. Very good. Thank you, Karen. Karen has given us a very clear perspective about her program and important information about Cape Cod and older adults. I would now like to turn to Ayana Parent. And Ayana, thank you. We will hear from Ayana, who is a licensed independent clinical social worker and trained in restorative yoga and yoga of 12-step recovery and multiple trauma-sensitive yoga-informed programs. Also, most interestingly, and if I may add, Ayana, you are a leader and organizer in the social justice movement and the founder of Love and Revolution, an action-based, anti-racist media group based on Cape Cod. We're honored to have you here this evening and looking forward to your presentation. Thank you.
Thank you. So hi, it's nice to see everybody, even though I can't see you. I'm picturing you all in my mind. So I'm the owner and founder of Be Free Wellness, which is a new nonprofit on Cape Cod. And our mission really is to help people with complex trauma move the difficult emotions out of their body. And the way that I do that is through movement, mindfulness, and meditation. So in the spirit of that, I actually don't do anything. I don't do even speaking without doing some kind of mindfulness first to bring everybody into the room. So what I'm going to ask you to do, it's just going to be like a minute. And if it's totally uncomfortable to you, don't worry about it. I can't really see you, so you're fine. Just going to center you for a second. So if everyone could really just sort of kind of sit tall in your chair, put both feet on the ground, drop your shoulders, close your eyes. And just take a couple really deep breaths in and out here, in through the nose, out through the mouth. And just keep your eyes closed. And just kind of notice your breath, notice your heart, notice your body. And then I just want you to notice and bring to your mind just what healing might look like for people of color in the world right now. Like, what image comes to your mind? And just take one more final, let's take a really deep breath in. So like fill up your chest, really fill it up and then let it out. You can exhale, you can get loud, you can, ooh, whatever you want to do. All right, nice. Now that we're all in the room together, I only have 15 minutes, you guys, and I do this kind of stuff and like weekend retreats. So I'm going to try and shorten it. And so it's going to come out really fast because I get really excited when I talk about stuff. I think for people of color, the stuff that I really want to bring home to you is that, so if you think about, so I don't have all the stats in front of me because they kind of make my brain crazy. But if you think about sort of for white people, what those stats are in terms of suicide and barriers to mental health and all those kinds of things, it's like triple and quadruple for people of color. And a lot of that has to do with access. A lot of that has to do with structural racism. A lot of that has to do with poverty. And a lot of it just has to do with general racism. So I do a lot of counseling right now, specifically because I specialize in doing sort of racial trauma and specific getting trauma out of the body, but also for people in recovery. So I do both. Those are my specialties. But I was talking with one of my young women the other day, and all this stuff, it was happening, and she came in the room and sat down, and I said, before we even talk about anything, I'm going to check in to see how you are feeling about being a person of color in the world right now. So that did two things, and it also signifies two very important things. One, I'm a person of color as a therapist. I can ask her that, right? That's very different. And so you see the disparities around sort of therapy, that there's very, very limited people of color in terms of anyone, therapists, doctors, you name it, right? There's it's very, very few. But that question needed to be asked in that moment for her to be able to articulate that, to understand that, to be validated by it, and then to be able to move about the world in a different way. If we don't start asking those hard questions and then start healing from that place, it's a very different relationship and a very different healing process for people of color. So what I want to also say is that if you can think about how, and I talk about brown bodies, white bodies, just because I'm a yoga teacher and that's how I talk about the world. If you're thinking about how white bodies move about the world and how people of color and Black bodies move about the world, Black bodies have to move around the world in a way that is survival and fight or flight. So they're always, any room they walk into, any place they go to, if they're walking around with their children, like if I go to the grocery store with my daughter, right? I am scanning the room for what danger might be happening. That happens to people of color when they walk in any room. So that right there, if you're thinking about the parasympathetic nerve and the nervous system, right? We all have anxiety. We all have things that come up around that kind of stuff. But for people of color, it's like times 1,000, because they have to exist with that, knowing that they have to either keep themselves safe from racism or their children. And that alone is exhausting, taxing, and oftentimes, unfortunately, does lead to suicide. And so that's really sort of where the racial trauma stuff comes in. But because of the structural stuff, if you want to take it on a macro level, right, we also have the racism and the social justice system, and I could do lectures on this forever. But because of that, there is all these inequities that happen that also land and people of color in jails, and really, in some ways, cage Black bodies instead of heal them. So once that process is started, then you have a whole nother host of things that then they have to deal with. And because they're dealing with the fight or flight all the time, right, they're looking for other ways to fill themselves, to feel better, which is then where lots of them get into difficult situations with recovery, with anything else that could make their bodies feel better, right? So that's like a really short way of sort of looking at it. There's so many other pieces to it, but that's sort of like the overall. In terms of healing, though, and in terms of just how to help, I think the way my studio does it and the way that we're looking towards creating a full wellness center, particularly with people of color in mind, is that really they heal in community. So there's a lot, they heal in groups, they heal with like-minded people. And so there's a couple things. So representation really, really does matter in healing places. They've also been mistreated by every single system in America. And so they're not going to trust any system that is the healthcare system. I'm not laughing. It's astonishing and heartbreaking. But so those spaces need to be created where BIPOC folks can have safe spaces for themselves to be able to heal, and then to bring white allies into that as well. There's also a power dynamic that happens when you're looking at, say, therapist and I say client. I call them members. They're not separate from me. So I think about healing in terms of a linear and adjoining way, right? Which is also very different than the hierarchy of power dynamics, in which is a very sort of white way of looking at healing. if you look at people of color and the way that those communities function, it's in a circle, right? So, and then there's a give and take, and it's a joining, and it's a learning, and it's a loving, and it's a giving. So there's all those multifaceted things that happen in terms of learning together. So this is a sort of a high level way of thinking of the power dynamic, which I know is structurally not going to change right now. But if we do want to look at wellness and how we do it, we got to look at community, we got to look at representation. We also have to look at health, because stress really does affect the body. So all these things, diabetes, all these other things that really come into these health disparities for people of color that end up actually, I would say, killing them in some ways, because they're not healing themselves. And a lot of it is survival mode, right? They just got to get through the day. And so sometimes even going to see a therapist, they're taking care of themselves, is not, don't have time, right? You're feeding your children because you have 5 jobs, you don't have health insurance, which is the other thing that ends up happening. And then you become last, right? You're last with the white supremacy in the world anyway, but then you become last to yourself. So if we're really going to look at healing, we got to look at it structurally, but also just sort of in a way that creates community and really, really works with those power dynamics that can create a sort of leveling and equity in terms of healing that's based on love and not necessarily based on a hierarchy of systems. But also movement and mindfulness, people don't really know how crucial it is to keep people alive. So the one thing that actually can calm your nervous system when you are really stressed out or you're in fight or flight is your breath. And not many people know that, right? It's like when you get a panic attack, people are, you can literally can't catch your breath and your heart is going fast. Body's really trying to get breath. So if we can teach people how to breathe and to really get the mindfulness tools, and mindfulness and meditation is not this crazy hokey thing that people think it is. It's really just being still and finding breath throughout the day so that you can calm your nervous system enough to really function. So if people of color, that is so crucial, because that can be the moment between sort of life and death, right? The suicidality rate for people of color is extremely high. And it's to alarming rates. And a lot of people don't know that the racial stuff, the microaggressions happen along the way. So by the time they're suicidal, it's not necessarily because they're, quote, depressed. It's because they're growing up Black in America, and it's really hard on your soul. It's hard to function in a way that brings joy. This sounds really horrible, awful, and depressing, but it's I'm saying it in this way because I just feel really passionate about there are ways we can heal people of color, and we really, as long as we're looking at specific ways and really helping how to really figure that piece out in a thoughtful way that creates community and not power dynamic and sort of erases the barriers, then there are possibilities. But a lot of it is going to take policy, and a lot of it is going to take really white allies being loud about the inequities of racism. How's that? Am I good?
You really have a little bit more time if you want to add
Oh,
anything
good.
else.
No, I was like, am I over? Oh, good. Okay, good. So I guess the other thing that I would just say is just about being human. And this is just a little plug for people in general, is that just racism overall really dehumanizes us. And that goes across the board. That goes for white bodies, Black bodies, people of color in general, Native, all of us. And then in order to really work on the mental health issues with our population, we have to look at it as creating better humans in the world, and look at it as a global issue that we are all responsible for, and not just people of color are responsible for in terms of taking care of each other, but that we really need to look at society in terms of how do we bring back some remove just this dehumanization of racism and really look at ourselves as human, and how to get just more breath and mindfulness back into the bodies.
What you've done for us this evening is understand suicide and its impact on individuals of color. It doesn't matter from what you were presenting, if it's a youth or adult and older. But it's most important to understand the impact on trauma as you've put forward. So have you actually found a reduction in your mindfulness exercises and the yoga, etc., of an individual's wanting to die or being suicidal, and that feeling decrease over time?
Yes, because the breath is so important for the, to actually that one thing that calms the parasympathetic nerve, it does automatically decrease the sense of fear and the sense of danger, even though obviously racism does exist and walking around the world is hard. Those kinds of tools can help you pause, and so that you're back in your body instead of living such in this fight or flight mode. So yes, it does, in my program, it does decrease pretty quickly. I'd say within the first 3 months of working with me, it's decreased quite a bit for most of them. That's a great question. Yeah, and it has to do with the movement too. I mean, the endorphins, obviously, when you're moving your body, my program, you have to breathe, but you also have to exercise. And, and that's can be from 15 minutes to an hour. It's not a whole thing, but movement is really the medicine for the body. I would say that movement are better healers than anything else ever will be. And it's just, you can access it anywhere.
Well, I want to thank you for your frankness and also offering information, which is a way of understanding how else suicide can be prevented. Very clear and thorough. With that, I would like to introduce to you and to the audience Heather White. And Heather is a member of the executive committee for the Massachusetts Coalition for Suicide Prevention, and she is the chair of this organization's advocacy committee. And she is the current area director for the American Foundation for Suicide Prevention chapters, quite recognized in Massachusetts and Vermont, and is a trained assist suicide intervention caregiver and suicide prevention trainer. We're looking forward to hearing from you. Thank you, Heather.
Good evening. Thank you all so much for having me. As Eileen mentioned, I'm with the American Foundation for Suicide Prevention, and it's my privilege to serve on boards like the Suicide Prevention Coalition here in Massachusetts and the different 988 work groups, both in Vermont and Massachusetts as well. I came to know AFSP about 9.5 years ago when I almost lost my own life to postpartum depression and suicide. That's sort of my elevator speech, but in my years in suicide prevention and learning about mental health, I've actually come to see that it was much more of a lifetime, a journey of mental health that precipitated in my postpartum time, but I've got a better understanding of this journey that so many of us are on for the lifespan, with major depressive disorder or anxiety, and also doing some more research into my own family history, and now there's perhaps a history of suicide in our family that we hadn't really uncovered when we were naive about mental health and about suicide before AFSP came into our lives. So I say all the time that, and Susan is in many meetings with me, and she's heard me say this, that AFSP has really saved my family and given me my life back. And for that, we're forever grateful. And we do many things at AFSP, but what I'm so happy to talk with you all about tonight is our advocacy efforts. I love that this organization is about getting involved in the civil process and learning how to advocate and be a voice on legislative matters that matter to you. Thank you, Susan. And that's exactly what I'm here to talk to you about tonight. There's many things that we could cover, but I'm thrilled to be able to talk with you tonight about the 988 implementation that we're going to be seeing coming very soon, and tell you a little bit about what that is, how it works, and how we can all help get involved with that. So currently, and if you don't have this number in your phone, please feel free to take out your cell phone right now and put the National Suicide Prevention Lifeline in your phone. It is 1-800-273-TALK. And if you're like me, you have to stop for a minute and think, okay, TALK. All right, that's 8255. So thank you, Susan. 1-800-273-8255. I actually had to go ahead and use 8255 as my little security password on my storage unit, just so I could remember it, so I wouldn't forget 8255. Well, so I probably shouldn't share that with too many people, but so that's the phone number right now to reach the National Suicide Prevention Lifeline. And AFSP, with many other partner organizations, started a push a few years ago to get that changed to a 3-digit number. Like we have 911 and we have 211. We even have a 3-digit number for DigSafe. If you need to do digging in your yard, you have to call a 3-digit number. And yet we still had this very long, hard to remember phone number for people that we expected to call in the height of a mental health crisis. So back in October of 2018, we did get the 988 Designation Act passed. That is going to set the stage for the Suicide Prevention Lifeline be changed to a 3-digit number. And that needs to be rolled out and implemented nationwide by July of 2022. So when we talk about how the states are going to do this, we need to start talking about it now, because this is the legislative session in which we can actually have an impact. Because by the time the new fiscal year starts, July 2022, it's too late. We need to have everything in place for this rollout July 2022. So we'll talk a little bit about why this change to a 3-digit number and why it is so important. The first, and I really wouldn't rank them, but I'll just say first so I keep my notes straight. The first is that it will lessen the burden on 911. You know, we see that that's not always the most appropriate response for someone to come to help someone who is in the middle of a mental health crisis right now, and it is a burden on our 911 system. So if we can separate out those mental health crisis calls, it will help the response time and take some of the burden off of the 911 system. Additionally, it's a cost-saving effort across the board, not only for our first responders. You know, it was great to hear Karen talk about the suicide prevention barriers that you have on the Cape. I'm in Western Massachusetts, and we are in the middle of a current advocacy, I guess you could say, or legislative fight right now for the barriers on the Franklin County Bridge, the French King Bridge. And we heard from a local law enforcement that it costs his city about $4,000 an hour when he has to send out his first responders on a suicide attempt or on a possible suicide call. And that's in Franklin County. You can only imagine how much more expensive that would be in other parts of our state. So we're saving money in that respect, and we're also saving money in our health costs as well, because very often what we see is when 911 is called for a mental health crisis, that person is put into the emergency room for many days often, and then they're put into the medical and the clinical system, and that's a very expensive route to take. When we have evidence that a call to the Suicide Prevention Lifeline or to our friends at Samaritans or our friends at 211 Call to Talk, when we have evidence supporting that those efforts save lives, but instead we're putting them through this very expensive path through our healthcare system when it's not always necessary. A few other reasons is that first, for everyone, the most clinical option might not be the most successful option. Sometimes when people are struggling with thoughts of suicide or with a mental health crisis, it's not just because of a physical condition. There's things in their lives that are happening. We know through our research that when a suicidal crisis has been reached, it's because of many intersecting factors in someone's life. It's your mental health condition, but it's an environmental factor. It's a historical factor. There's all these things that are culminating in a suicidal crisis. And putting someone into a clinical setting is not always the best fit for everyone. Sometimes the peer-to-peer model is much more successful. Another reason why a 3-digit number is great is that we know, and especially we're talking so much now about our BIPOC communities and our older communities, sometimes, whether it's culturally or from a family history, people might not have a great relationship with law enforcement or with 911. And that could be considered a barrier to access. If they're hesitant to call 911 in the middle of a mental health crisis for any reason, whether there's been negative interactions with the police or first responders in the past, be that culturally or with a past mental health condition. You know, we always say sometimes people might not want you to call 911 because they don't know what's going to happen when they get into the system. But sometimes they don't want you to call 911 because they know exactly what's going to happen when they get put into the system, because it might have been many times that they've called 911, they've been left in an emergency room waiting for a bed for days on end with no one to speak with, no one to talk to, when they really just needed a suicide intervention on the phone at the time of the crisis. And lastly, one of the biggest reasons that we feel it's important is for the sense of parity. You know, I'm thinking folks are familiar with that term, where we have a sense of parity between our mental health and our physical health. We talk about this often at AFSP about how we have to start making this connection that our mental health has to be treated the same as our physical health. We have a lot of great analogies about this, a lot of ways to help bring that point home to people. But the same needs to be true from 911 to 988. If you are having a physical health crisis, you call a 3-digit number. If you're having a mental health crisis, you call a 3-digit number. And the same has to be true when it comes to funding these two different phone numbers. And we'll get to that in a moment. So we'll talk a little bit about how this is going to work. And it's funny, I have Karen here and anyone from the Samaritans who could speak to this so eloquently as well, but I'm happy to do my best. So right now we have 5 call centers across Massachusetts, and they are receiving phone calls both from their own individual lines and also from our 1-800-273-TALK phone number. Currently, only about 67% of calls coming from Massachusetts to the National Lifeline are being answered here in Massachusetts. That means there's an additional wait time as they relay that phone call to somewhere else. Imagine finally getting up the courage to make a call to the Lifeline and being put on hold while they try to connect you to a center that can take your call. And then also they don't have the local resources to wrap back around that person when that call gets transferred out of state. Now, I will say 67% is not that great, but it is not that bad. I work closely with Vermont as well, and they are currently working anywhere between 2 and 3% of calls to the National Lifeline from Vermont are actually answered in Vermont. So right now the call comes through and they do a real-time communication, a real-time suicide intervention with someone who is in crisis, and then we provide wraparound support. We already know that the numbers to these lifelines are increasing dramatically over the past 14 months, even in the times leading up to COVID. We saw these numbers increasing. We also know that when this 988 transition happens, there will be a lot of awareness campaigns. There will be a lot of efforts being put into promoting this number. So we expect those numbers to jump even higher once this number is up and rolling. So we need to make sure that our call centers have the resources that they need to answer those phone calls when people call them. So the Designation Act back in October of 2018 did allow for each state to come up with a way to fund these as a sustainable way. And it can be similar to the way 911 is funded. So right now in Massachusetts, 911 is funded by a $1 per month per telephone line fee that you will see if you checked your bill. What we are proposing here in Massachusetts is a 25-cent fee per month per cell phone line. And our estimates is that will bring in about $4 million or so. That will be designated strictly for the call centers, for the 988 number, and then wrap around and resources out for those community members as well. one big difference between how 911 operates and 988 operates, and this is a question that we get asked often. If you call, someone said to me the other day, well, when I call 988, who's going to show up at my house? So no, that's not how this will work. If you call 911, they will come to your home. If you call 988, you will be connected to our fully trained Lifeline call center volunteers who will walk you through your steps to calm yourself down, to come down from your mental health crisis, from your suicidal crisis, and get you the resources you need to move forward. So that's an important differentiation to keep in mind. We are also looking at part of this legislation and part of this funding to help support our mobile crisis units as well, so they can still be a part of this. But it is an important distinction to know the difference between how 911 and 988 will function. So what can we all do? This is where our advocacy really comes into play right now. We have seen bills be introduced all over the country, which is great. Some of them, a vast majority of them, are going along the lines of the 911 funding. We have one state that's still struggling, and they said, well, we'll just keep applying for grants. It'll be fine. And I thought, if I'm having a heart attack and I call 911, I don't want to sit there hoping that they got their grant funding this cycle for someone to answer the phone. That needs to be there, and so we are very adamant at AFSP that there has to be parity. These have to be funded the same way across the country. And we shouldn't have to be wondering whether or not our grant application got submitted on time for our 988 call centers to be there when we need them. So currently in Massachusetts, we do have two bills, one from the House and one from the Senate. The House bill was put forth by Marjorie Decker, and the Senate bill was put forward by Senator Sear. We just recently had our state suicide prevention advocacy day with the Massachusetts Coalition for Suicide Prevention, where we bring in the general public, our volunteers, those who work in this field, those who have lost a loved one to suicide, or those who have struggled with suicide. We bring them all together and we teach them how to advocate, how to reach out to their local representatives, their senators, how to build a year-round relationship with them, and most importantly, how to talk with them safely about suicide. Suicide is not an easy topic to discuss, especially if you've been touched by it in your life. And we also want to make sure that those who are speaking on it speak safely about it, because we don't want to have any type of suicidal contagion when we start talking about a difficult subject, whether that be with a senator's office or with our friends and family. So we go through a whole day long training. We figure out the best way to talk to our state legislators, and we're very happy to let you know that both of the bills have been moved on to the committee, which is a big step if you're familiar with the legislative process. They have both been sent to the Committee on Mental Health, Substance Use, and Recovery. So that is a great step forward. Senator Sear and Senator John Velas, who are strong supporters of ours at AFSP and the message, the importance of suicide prevention, are on that committee. I'm seeing in the chat box of those quick bill numbers. Susan, if I rattled those off, or Eileen, if you wouldn't mind putting those into the chat box for me. It is S1274 and H1281. Those are the two bills around the 988 legislation right now. Again, they are currently in the Joint Committee, excuse me. And we're very optimistic that it's a good step forward. We do also meet on budgetary line items for the DPH line item as well. That came in a little low on the House side, but we're looking forward to when the Senate takes a look at the budget. But there's some great websites, thank you, Susan, where you can check that out. And if you want to get more involved in advocacy, we have a field advocate program here at AFSP where we will direct you right to an action center where in just a matter of seconds, you can send your thoughts to your representatives on issues that matter to you. So thank you so much. As my other two panelists have said, I could literally talk about this or any subject around suicide prevention all night, but I'm thrilled that you've asked us to join us, and I hope that helps. Great, Rosemary, so do I.
Very clear. And thank you, Heather, for summing up the importance of the change to the three numbers of 988. And your advocacy is just really impressive. With that, and I want to again thank each of the presenters, Karen, Ellery Jones, Ayanna Parent, and Heather White. We've heard from each, and what's really interesting, they have given us a gamut of important and sensitive, time-sensitive information, both legislatively, the importance of advocacy, but the importance of as well as understanding the impact of suicide on persons of color, the importance of tying it into cognitive and mindfulness and breathing, the role of the Good Samaritan program that many of us know and coming back and forth over our two bridges to get onto the Cape, and most importantly, the array of support groups. With that, there are questions that have been identified in our chat box, as well as if participants take a look at the chat box, there's also recommendations of where to access information. But there are some key questions. And Karen, if you could help me identify those questions, thank you.
Our first question relates to the Means Matter study, which has been interesting because it relates to guns in homes. And could you please address that?
Thank you, Karen. I'm going to suggest, Ayanna, are you aware at all of this particular challenge in regards to guns in homes?
No.
Eileen, I could speak on that if you'd like.
If you could start, and then the importance of the challenge of guns in homes and suicide is something I think the three of you can also present. So thank you, Heather, for talking about it specifically, and then more open-ended for Ayanna and for Karen.
Yeah, sure, absolutely. So thank you for bringing that point up. We know that suicide by firearm is one of the major components of firearms right now. In Massachusetts, this past year, we had about 57% of all firearms deaths were suicides. You know, if you really want to get serious about saving lives through firearm safety, then the conversation should be about suicide prevention. Because the majority of times a firearm is used in a fatality, it's a suicide. So that's really where the focus should be if you want to save the most amount of lives. Here in Massachusetts, about 22% of all suicides are by a firearm. Now, in comparison, in a state like Vermont, we're seeing more like 92% of suicides being with a firearm, because there's a vast majority, there's so many more firearms in the homes and in the communities. But you're absolutely right. We have seen that once you take away someone's first choice when it comes to suicide, whether that's a firearm or a famous bridge, once you take that option away, they most of the time do not have a second option planned. So if we can get into the firearms owning community and start talking with them about firearm safety, that's the best way to start saving lives. You know, we work closely with the firearms retailers, and they're welcoming us. They want us into that world because they're losing friends, they're losing family members, they're losing customers. Anytime a firearm is used inappropriately, it reflects poorly on the entire firearms owning community. So they really are bringing us in and open to the idea of suicide prevention, and as part of firearms ownership, as part of getting your license to carry, as part of having a firearm, learning suicide prevention along with it. So there is work being done. There's so much more to be done. But But my line is always, if you want to get serious about cutting down on firearms violence, then your message should be suicide prevention.
Mhm.
Interesting and an important message you've given us, Heather. Anna, the reason I reached out to you first is because of your programming. And if you have found in your program that you find individuals who over time may talk about the availability of a gun or wanting to kill themselves, has that occurred? And if so, how have you addressed this specifically?
Such an interesting question. Not specifically with guns. And I was looking just at the chat too, just about statistics too, and how some of this stuff gets reported and the accuracy of those. So no, a lot of it, for me, when I've worked with folks, doesn't surround guns. I have, when I've worked in Boston, some of it did, but not necessarily around suicide, although the access to them is what is really scary. But then again, when you're in a mental health crisis, access to anything can really be seen as a way to harm yourself. So obviously guns are super scary, and access to guns in general, I think for homicidal purposes is really scary. So I mean, I think guns in general need a whole overhauling of. That's my own personal view.
You're absolutely right, but your response to this is very helpful, and I thank you. And I'm going to also just turn to Karen. For the Good Samaritans, has this issue come up in the calls to Good Samaritans?
We have had a few callers who are suicidal with guns in their laps, absolutely. And, I agree 100% with what, Heather has said about firearms. And, you look at the states with the highest firearm ownerships are also the states that have the most suicides by firearms. So it's not that we want to take away firearms. We just want reasonable gun safety laws. We want people to lock their weapons. A majority of gun owners don't adequately store their weapons. So if someone is in a suicidal crisis and they have access to a firearm, they're going to take that, and most likely they're going to kill themselves. It's the highest lethality, and most people don't survive. And the Rocky Mountain states, all of them, huge gun ownership rates.
It's an important point, again, about gun safety.
Yeah,
But when we talk about suicide, I'm not discounting the challenges regarding guns, but I'd like to ask the provider challenge. And if each of you, and then just put your hand up who would like to go first, how on the Cape, for example, there is a need, there's a lack of providers overall for mental health.
Mm-hmm.
Number two, there's definitely a lack of providers who are of color, and how that challenge can be addressed. Who would like to kind of address that issue first? Karen, thank you.
Yeah, I'll just talk about what we hear on the crisis line from people who identify themselves as a Cape and Islands resident, is that it is so hard to find a therapist. The wait to see a therapist is weeks, if not months. And it's unacceptable. And we could talk about even, to see your GP, your primary care physician, it's the same thing. It's really difficult. So that prevents a lot of people from getting the help that they need to prevent another suicide crisis. With the Cape and Islands too, is that we have a lot of unemployment during the winter season that leads to depression and loneliness and isolation and financial difficulties and substance abuse. And it all wraps up into a violent storm. But I wish that we have a lot of interns who volunteer with us, and I always tell them they're interns from Westfield State or from Bridgewater, and they're psychology majors or nursing students. And I'll say, you will never get a better window into the mental health deficiencies than when you're working on a crisis line and you hear people pleading for help and not being able to get it.
You've clearly identified the issue. I would go back to both Ayana and Heather, and which of you want to respond to my taking this question further? What can occur when we well know there is this lack of providers and lack of providers of color?
Ayana, did you want to go first?
Sure, doesn't matter. Yeah, the lack of providers is I mean, across the board, it's astonishing. But never mind lack of providers for people of color. And again, it all stems from structural racism and just the lack of people that are trained, but not because they don't want to be trained. I think it has to do with equity is a lot of it. So I think what we have to do is really offer programs for people that are interested in doing that for people of color, and really put our money where our mouth is and get people trained and pay for them to get trained, for people of color to really get trained in being mental health providers and getting the training that we do. I think the way that we really have to look at the wealth gap there in terms of how we're looking at that. Not necessarily people of color not necessarily going to have money to get educated and to be able to get masters, which you cannot get a job, I'm telling you, and you cannot bill insurances unless you have a license, right? I have an LICSW, I can bill it for any insurance I want. But if you're in any other realm, that takes a lot of education, a lot of money. Sorry, I'm getting angry because like Sally Mae keeps calling me. And it puts you in debt. I'm in debt, right? So, and I still have the job, which is again why I went nonprofit, because I believe that the way to solve this problem is by just creating funding opportunities where I can then help people regardless of their economic background. And I don't have to deal with insurances. I don't have to deal with any of that. I just create these equity situations in which the nonprofit can reach out and help.
We do have some other questions from the chat as well. I just wanted to let you know that.
And thank you, Karen. Just to finish this, in regards to the Be Free Wellness, if I understood in your presentation, you were also identifying that it's not just the yoga and etc. exercises, that it's a whole, you yourself are providing an important intervention.
Yeah, I personally do individual therapy, and I've developed a coaching model in which I've trained 10 people to do, and that will be rolling. So there'll be a lot of other people trained in how to, and specifically we're trained in all kinds of things, but a part of the training is how to address the mental health needs of people of color.
Thank you.
And people in recovery, specifically on Cape Cod.
And Heather, do you want to add anything else to what you've heard already?
Two quick things that I will add. First being the huge increase in telehealth that we have seen during the COVID pandemic, which we do think we will see continue to grow, which can help with barriers to access, to getting to appointments, getting to see people, getting off the island to get a meeting or to get an appointment with someone. Also, it's a systemic problem, as Ayana mentioned, putting in together some incentive programs to get people into these programs, to get them into the schools, to get them into the mental health programming, counseling programs. But I will flip it on its ear a little bit, if you don't mind. It's something I love to do every now and then. Think of how many lives we have saved by the vast majority of people that need to learn CPR, right? You learn CPR, you can keep someone alive until they can be seen by a health professional. If we can start building suicide safer communities where all of us have the basic tools and skills that we need to help a friend or a loved one through a mental health crisis, we can all be there for each other, and we can help and we can support them until they can get in to see a mental health professional. And I've seen it a few times mentioned in the chat box, it's peer-to-peer support. So many people are required to be CPR trained, and you are exponentially more likely to come across someone in your lifetime having a mental health crisis than you will ever need to use those CPR skills on someone. Yet we aren't teaching the very basics of how to help someone in a crisis. And that's really where we believe educating the community, our teachers, our moms, our dads, our brothers, our coworkers, on how to help a friend or loved one that's struggling and keep them safe until they can get the help that they need.
Thank you, Heather. Is that part of the bills that you talked about?
There is some peer support programming. I believe it's already been referenced in the chat box. There's some additional legislation for peer support as well.
Excellent. I'm going to turn to Karen. Other questions have come through the chat box. Thank you, Karen.
What do you see as the role of councils on aging in supporting connectedness and suicide prevention efforts?
Karen?
Our local Council of Agings are absolutely fabulous organizations. They've always been a pillar in our communities, but particularly during the pandemic, they have taken on so much additional work, calling seniors who are at risk of loneliness. They are unsung heroes as far as I'm concerned. They're unbelievable. They have done so much work, and we get a lot of referrals from the Council of Agings for our senior outreach program. But the Council of Agings too, I mean, that's a great place for people to go when the pandemic is over, where we can all gather together. They have wonderful programs. And again, that builds a community. That is really so important. It connects people together who might just sit in their home and not engage in the community. They're wonderful. They're such an integral part of our community here on Cape Cod because it's sort of isolating here on Cape Cod in some of the communities. Transportation is a big issue. A lot of the Council of Agings provide transportation to the centers. They do so much work. I'm a big fan.
Obviously,
We're actually getting a new one here in Sandwich. I'm a little
excellent.
too young to go, but when I'm ready, I'll be there.
Karen Maza, another question that's come in the chat box.
What are some of the warning signs of a person considering suicide, and what should one first do to lower the risk?
Ayana, you kind of talked about that. Do you want to address that question first regarding the warning signs?
Yeah, I mean, I think it all varies per person and, per community. Obviously, so it can go both ways, but certainly affect changes in, anyone's regular routine, talk of, consistent depression, anxiety, suicidal, someone isolating more, and just really reaching out and helping. I mean, that peer-to-peer support model is brilliant, just in terms of the connection piece and how you can actually really help someone in terms of that, but isolation's certainly a big one. Obviously, depression's a big one. And not to be afraid to tell somebody. I've had more people tell me than not. Most of the time people really do want help. And so what ends up happening is when people don't pass on the information and the person doesn't feel really cared for, or, obviously that's where all that stuff's coming from. But yeah, some of these other guys can probably, because you guys do all trainings on this stuff, can do it. I just feel it.
Thank you. Karen or Heather?
Some of the actual signs of someone might be thinking about suicide is them saying, I'm thinking about suicide. I want to kill myself. I'm a burden. My life is hopeless. They start putting their affairs in order. They start giving away items. They're not sleeping. They're not taking care of themselves. And as Ayana said, I mean, sometimes if you have to be able to ask them, are you thinking about suicide? And Heather knows this too, is that when you're in the suicide prevention field, is that you always, you have to be aware of people, and you have to be able to ask the question, are you feeling so alone or so helpless or so bad that you're thinking about taking your life? A lot of people don't want to ask that because they're afraid of what the answer might be. But we have found on the crisis line, when our volunteers ask this question, callers will say, yeah, I am. I really am. And they're so happy that they can sort of, like, someone asked them, someone actually listened to them and heard them. And that sometimes will diffuse the situation just enough so they can start talking about other issues. But we always say, like, it's the same thing when, you're walking by someone on the street and like, hi, how are you? And you don't even wait for their response. If you're going to ask someone, are you feeling suicidal? You better make sure you stop and you wait to hear the answer. And what, Heather, you were saying about CPR for people, we do QPR. And if anyone is ever interested in QPR training, I'm a trainer and we do it for free. So we're happy to do that program, 2.5 hour, 2 hour program for free. And more people that know the signs and know what to do, because it's scary not knowing what to do.
I'm going to ask a question. It's well answered by both Karen and Ayana, our first question, but this question takes off from it. As a family member, many times, perhaps that your family member is presenting suicidal possibility. And when, in fact, they reach out to a provider many times, they hear confidentiality, security issues, and I can't speak with you. How do you handle that? When the family member knows something is occurring, and in fact, there's a barrier to them being heard on behalf of their call for their family member. Somebody want to jump in?
Look at us all jumping in on this one. This is a tough one, right, Karen? This is not an easy one. It's a hard one. A lot of this came up with the parity bill a couple of years ago, when we started putting together a health insurance parity bill where your mental health had to be covered by insurance the same way your physical health had to be. And a lot of these HIPAA questions came into play. And Karen, jump in or Ayana, jump in if you know, but a lot of them have not been resolved. If they're an adult, if they're over the age of consent, then their doctor doesn't have to share with you. And it's so hard for someone who's trying to support a loved one when you just want to know, did they have a follow-up appointment that they didn't go to? Or what is the right prescriptions and medications they're supposed to be taking every day? And if you can't get a straight answer from your loved one, it's very frustrating. I'm sorry, I only have the frustrations the personal experience and frustrations to share on that. I don't know if Karen or Ayana or maybe even Susan might have more in our chat box from a family's member's perspective.
Ayana or Karen, any other additional response to what you do or what can be done?
I'm just echoing what Heather has said, is that you just see a lot of frustration on the family members who can't get information, which can be a matter of life and death. And it's very frustrating. We hear that on the crisis line, and it's really hard because we don't have any answers on what to do.
Thank you.
A great resource I could provide. Oh, I'm sorry, I didn't mean to interrupt you or Ayana, Eileen, but a great resource could be your local NAMI office, the National Association on Mental Illness. They have some great opportunities, some great family support groups that are offered and supporting loved ones with lived experience. We're actually piloting a brand new program here in Massachusetts for supporting for loved ones, supporting those with lived experience in suicidal attempts. But NAMI could be a great resource for families as well.
The Cape and Islands National Alliance for the Mentally Ill. Thank you. Ayana, any other, what you do as a therapist?
Yeah, I mean, the HIPAA laws are tricky. It's a little more flexible, which is why I designed my coaching model, because I do work so closely with community, and that the Be Free Wellness community is built as a community, and we all care about each other. And in the way that we talk about that language, if one of us is concerned about each other, we're going to share information with each other just because we're worried. That goes for the same as the families of our folks. So we all have a really tight relationship, and so it's very fluid in terms of how we talk. That gets trickier when you're dealing with someone's doctor. You know, the best you can do is try to get releases and stuff ahead of time, which, you know, I do. But they all pretty much know, even if they're not in my care and they're just in my community. People come tell me often that they're worried about so-and-so, and can I just check in with them? But that's a language we put right up front, because I am dealing with so many people that experience trauma, and that suicide can happen within 5 minutes of an interaction with somebody, can trigger them. So it's pretty sensitive, but we're also very open and very communal in how we just take care of each other.
And what you said right now, that as a therapist, you are already prepared by release forms, signed release forms, etc. Thank you. I will go back now to Karen Maza. Any other questions in the chat box?
How do you feel about the spread of marijuana being normalized and the idea that it is a treatment for mental distress like PTSD? This is being pushed by pro-pot businesses and their marketing. I heard it at a public forum for recreational marijuana business.
Anyone want to jump in on this question? Please.
I don't have enough expertise in that area, so I'm going to have to pass.
Very honest of you.
Ayana.
I will say I will be happy to do some research and report back to the group on that. No, I didn't mean, Karen, I didn't mean it that way. That is not what I meant. I'll be happy to put some feelers out into our partners and see if there's any research on that and report back to the group.
Very helpful. And Ayana, any other response?
So there's a couple ways you could look at that. You know, it is a business, and I know this is like a tricky area. And I think it has to do a lot with like people's personal opinions about sort of how you heal and recovery and what's okay and what's not okay, and medicinal healing. I'm only going to say that I know that there's a whole thing around it, and I don't necessarily agree with it in terms of recreational stuff. However, I have worked with a lot of people in which when it's done safely through the doctor,
right.
It has helped a lot. So
good response. Thank you. Karen Maza, any other questions we should cover as we come to a close?
No, no more questions, but I will say that there is a great deal of resource information in the chat. And so I think that one of the things that the League can do, along with posting the recording on our website, is to also share some of these resources.
Excellent. We thank you. With that, and having no other questions and coming close to closure.
Can I just make one more comment? Sorry.
Absolutely.
Okay. Someone just mentioned about Narcan, and so some of what's tricky with suicide reporting, particularly for the recovery community and for people of color, is a lot of it has to do with like overdose and opioids and substance use, and then people of color just not being on the map in terms of, you know, who they are, and so that disparity is there as well. But people can certainly, I don't want to go over time, can reach out to me. I have lots of resources about Narcan and how to get you trained and that kind of stuff, because overdoses, particularly on Cape Cod, are huge, and a lot of the alcohol overdoses are also huge and are suicidal, although that wouldn't be documented in a medical record. It would be documented as something completely different, although it's suicide hands down. So I just wanted to make sure that was touched on in terms of addiction, particularly in Cape Cod.
The importance of Narcan, etc., is very, as you just identified for the Cape, a key intervention. And I thank you for bringing it up and also being available as a resource. With that, and to the audience, we thank our excellent presenters. Your ability to talk about suicide in a way that's open, frank, honest, with a little just of smile and humor to balance a very serious issue is appreciated. And kudos to each of you in taking time out of your busy schedules, and to your staff as well for everything and everybody and what's being done to prevent suicide. In that regard, this program will in fact be videoed and be able to be accessed through the League's YouTube channel and through the League's website, which is on LWVCCA.org, and it'll go on the chat shortly. Kudos, everybody, and we thank you.